Welcome to the third and final video in our regional anatomy revision series. In this video, we are covering the forearm, wrist and hand. We will begin with the radius and ulna, then move through the flexor and extensor compartments of forearm. After that, we'll revise the major nerves, blood supply, pronation and supination, the wrist joint, carpal bones, ligaments and carpal tunnel. Finally, we'll cover the intrinsic muscles of the hand, grip and pinch, wrist biomechanics and some important clinical conditions. As with the previous videos, this is focused on anatomy revision and applied anatomy. We are not covering physiotherapy treatment in this series. Let's begin with the forearm. Our sequence is bones, compartments, muscles, nerves, blood supply, pronation and supination, wrist, carpal bones, hand muscles, grip and pinch, biomechanics, clinical anatomy. At the end, we'll have a rapid fire revision section. Let's start with the two bones of the forearm. The forearm contains two bones, radius and ulna. In the anatomical position, the radius is on the lateral or the thumb side, and the ulna is on the medial or little finger side. The two bones are connected by the interosseous membrane. They work together to provide structural support and allow the forearm to rotate during pronation and supination. Remember the basic orientation. Radius is lateral, ulna is medial. Important landmarks of the radius include the head, neck, and radial tuberosity proximally. Distally, we have the ulnar notch and radial styloid process. The radial head participates in the proximal radioulnar joint and also articulates with the capitulum of humerus. The radial styloid is an important landmark at the wrist. So, when looking at the radius, think head proximally, styloid distally. The proximal ulna has several important landmarks. The olecranon forms the prominent posterior part of the elbow. The coronoid process projects anteriorly. Together, they form the trochlear notch, which articulates with the trochlea of the humerus. Distally, the ulna has a head and styloid process. Unlike the radius, the distal ulna does not directly form the main radiocarpal articulation because the articular disc lies between the ulna and carpal bones. The interosseous membrane connects the radius and ulna along much of their length. It provides attachment for muscles and contributes to stability between two bones. It also helps transmit forces between the radius and ulna. So remember its three broad roles: connection, muscle attachment, and force transmission. The forearm is broadly divided into anterior flexor-pronator compartment and posterior extensor-supinator compartment. The anterior compartment is mainly involved in wrist and finger flexion and pronation. The posterior compartment is mainly involved in wrist and finger extension and supination. This compartment organization makes the muscle anatomy much easier to remember. The superficial anterior muscles include the pronator teres, flexor carpi radialis, palmaris longus, and flexor carpi ulnaris. Their names already give you some clues. Pronator teres contributes to pronation. Flexor carpi radialis flexes and radially deviates the wrist. Palmaris longus contributes to wrist flexion and tenses the palmar or aponeurosis. Flexor carpi ulnaris flexes and ulnarly deviates the wrist. The main muscle in the intermediate layer is flexor digitorum superficialis. Its tendons travel towards the fingers. The important action to remember is FDS flexes the proximal interphalangeal joints. So FDS is PIP flexion. The deep anterior compartment contains flexor digitorum profundus, flexor pollicis longus, and pronator quadratus. FDP flexes the distal interphalangeal joint. FPL flexes the thumb interphalangeal joint. Pronator quadratus pronates the forearm. So the key associations are FDP equals to DIP, FPL equals to thumb IP, and pronator quadratus equals to pronation. Let's organize the anterior compartment from superficial to deep. The superficial muscles: pronator teres, FCR, palmaris longus, and FCU. Intermediate is FDS, and deep is FTP, FBL, and pronator quadratus. Most of these muscles are supplied by median nerve or its branches, with an important exception, that is the flexor carpi ulnaris and the medial part of FDP, which are supplied by the ulnar nerve. This is your complete flexor-pronator muscle table. When revising it, don't try to memorize everything at once. Start with action, then nerve, then origin insertion. FTS versus FTP. This is a very important distinction. Flexor digitorum superficialis inserts on the middle phalanges. Therefore, it flexes the PIP joint. Flexor digitorum profundus travels deeper and inserts on the distal phalanges. Therefore, it flexes the DIP joint. So, the easiest exam memory is superficialis PIP, profundus DIP. The flexor pollicis longus runs through the forearm and inserts on the distal phalanx of the thumb. Its main action is flexion of the thumb, IP joint. So compare FPL to thumb IP and the intrinsic thumb flexor, flexor pollicis brevis, which mainly acts at the thumb MCP joint. This distinction becomes important when we study the intrinsic muscles of the hand. Now let's move to the posterior compartment. The superficial muscles include brachioradialis, extensor carpi radialis longus, extensor carpi radialis brevis, extensor digitorum, extensor digiti minimi, and extensor carpi ulnaris. Many of these muscles extend the wrist or fingers. Brachioradialis is slightly different. Although it is located in the posterior or lateral forearm region, its major action is elbow flexion, particularly with the forearm in neutral position. The deep muscles include supinator, abductor pollicis longus, extensor pollicis brevis, extensor pollicis longus, and extensor indicis. The thumb muscles are especially important. APL abducts the thumb, EPB extends the thumb at MCP joint, EPL extends the thumb at the IP joint, and extensor indicis extends the index finger, and supinator produces forearm supination. Let's organize the posterior compartment. The superficial group mainly includes the major wrist and finger extensors. The deep group contains the important thumb extensors, abductor pollicis longus, extensor indicis, and supinatum. Most of these muscles are supplied by radial nerve or its deep branch, the posterior interosseous nerve. This master table brings together the major extensor muscles. These functional relationships are more useful for quick recall than simply memorizing names. The radial nerve divides near the elbow into superficial and deep branches. The deep branch passes through the supinator and continues as the posterior interosseous nerve. The superficial branch is mainly sensory. The posterior interosseous nerve supplies many of the muscles in the posterior forearm. So the key pathway is radial nerve, deep branch through supinator, posterior interosseous nerve. The radial nerve system supplies the major muscles responsible for wrist extension, finger extension, and thumb extension. This is why injury to the radial nerve or its branches can produce significant loss of extension. The median nerve supplies most of the anterior forearm muscles. It gives rise to the anterior interosseous nerve, which supplies flexor pollicis longus, pronator quadratus, and a part of flexor digitorum profundus. The ulnar nerve supplies flexor carpi ulnaris and the medial portion of flexor digitorum profundus. Then it continues towards the hand. Let's summarize the three major nerve systems. Median nerve, most flexors, pronators. Anterior interosseous nerve, FPL, pronator quadratus, and a part of FDP. Ulnar nerve, FCU and medial FDP. Radial nerve and posterior interosseous nerve. Extensor-supinator muscles. The main arterial supply comes from the radial and ulnar arteries. They arise from the brachial artery near the elbow. Branches of these vessels supply the anterior and posterior compartments. The common interosseous artery arises from the ulnar artery and divides into anterior and posterior interosseous arteries. Now let's look at pronation. During pronation, the radius rotates and crosses over the ulna. The major pronators are pronator teres and pronator quadratus. Pronator teres is particularly useful for faster or resisted pronation. Pronator quadratus is the deeper distal pronator. During supination, the radius returns to a position roughly parallel with the ulna. The major muscles are biceps brachii and supinator. Biceps is particularly powerful when the elbow is flexed. Supinator produces supination without requiring elbow flexion. Let's compare them. Pronation by pronator teres, pronator quadratus, the radius crosses over the ulna. In supination by biceps brachii and supinator, the radius becomes more parallel with the ulna. Pronator syndrome involves compression or irritation of the median nerve in the proximal forearm region. One potential site is around the pronator teres. So when you hear pronator syndrome, think about median nerve in the proximal forearm. Intersection syndrome occurs around the dorsal distal forearm where tendons from the first dorsal compartment cross tendons of the second dorsal compartment. The important structures are abductor pollicis longus and extensor pollicis brevis crossing over extensor carpi radialis longus and brevis. The key here is the anatomical intersection, and that is why the name. As we earlier saw, the forearm contains relatively closed facial compartments. An increase in pressure can compromise blood flow and nerve function. This is an important clinical anatomy relationship. Now we move distally to the wrist. The wrist complex involves the distal radius, distal ulna, carpal bones, and associated soft tissues. The major joints include the radiocarpal joint and the distal radioulnar joint. The wrist allows flexion, extension, radial deviation, and ulnar deviation. And importantly, the wrist position strongly influences hand function and grip. The radiocarpal joint is formed primarily between the distal radius and the proximal carpal row. The main carpal bones participating are scaphoid, lunate, and triquetrum, with the exact contact depending on the position and articular disc. The distal ulna is separated from the carpal bones by articular disc of the triangular fibrocartilage complex. There are 8 carpal bones arranged in 2 rows. The proximal row from lateral to medial is scaphoid, lunate, triquetrum, and pisiform. The distal row is trapezium, trapezoid, capitate, and hamate. This is one list you should know almost automatically. A common mnemonic is some lovers try positions that they can't handle. Here are some high yield facts. The scaphoid is the most commonly fractured carpal bone. The trapezium articulates with the first metacarpal and is therefore very important for thumb movement. The capitate is the largest carpal bone. Pisiform is a sesamoid bone with the tendon of flexor carpi ulnaris. And the lunate is clinically important in relation to carpal instability and dislocation. The wrist has an extensive ligament system that contributes to stability. There are important palmar and dorsal radiocarpal ligaments, collateral ligaments, and intercarpal ligaments. Rather than trying to memorize every small ligament, focus on overall principle. Wrist ligaments maintain relationships between the radius, ulna, and carpal bones while allowing controlled mobility. The flexor retinaculum, also called the transverse carpal ligament, forms the roof of the carpal tunnel. It spans the concavity formed by the carpal bones. Its attachments include the scaphoid and trapezium on the lateral side and pisiform and hook of hamate on the medial side. This creates the carpal tunnel underneath. Now let's look inside the carpal tunnel. The tunnel contains median nerve and 9 flexor tendons, 4 FDS, 4 FDP, and 1 FPL. So the total is 9 tendons plus 1 nerve. The median nerve is the structure that is clinically important in carpal tunnel. The carpal bones form the walls and floor of the tunnel. The flexor retinaculum forms the roof. Important landmarks include scaphoid and trapezium laterally and pisiform and hook of Hammett medially. Now let's move into the hand. The skeleton consists of 8 carpals, 5 metacarpals, and phalanges. The thumb has 2 phalanges, proximal and distal. The other fingers have 3 phalanges, proximal, middle, and distal. This is basic anatomy, but it is important because the muscle and tendon action depend on these. The Thenar group controls important movements of the thumb. The main muscles are abductor pollicis brevis, flexor pollicis brevis, and opponens pollicis. Adductor pollicis is also functionally important but belongs to a different nerve supply group. The thenar muscles are critical for thumb opposition and precision grip. The hypothenar group is associated with the little finger. The major muscles include abductor digiti minimi, flexor digiti minimi brevis, and opponens digiti minimi. The main role is movement and positioning of the fifth digit. So the simple comparison is thenar thumb, hypothenar little finger. There are 4 lumbricals. The unique action is flexion of MCP joints combined with the extension of IP joints. This is a very important functional pattern. They are also important for coordinated finger positioning during precision movements. The interossei are divided into dorsal interossei and palmar interossei. The classic mnemonic is DAB, dorsal abduct, and PAD, palmar adduct. So dorsal interossei abduct the fingers away from the middle finger. Palmar interossei adduct the fingers towards the middle finger. Now comes another extremely high yield slide, the median nerve, which supplies the loaf group. L, first and second lumbricals. O, opponens pollicis. A, abductor pollicis brevis. F, flexor pollicis brevis, mainly the superficial head. The ulnar nerve supplies most of the remaining intrinsic muscles of the hand. Now let's talk about grip. Power grip is used when we need to generate force. Examples include cylindrical grip, spherical grip, and hook grip. These grips require coordinated activity of the long finger flexor, intrinsic muscles, and appropriate wrist stabilization. A stable wrist provides a mechanical base from which the fingers can generate force. So, hand function is not just about finger muscles, the wrist position is also extremely important. Precision grips are used for accurate manipulation of small objects. Examples include tip to tip pinch, pad to pad pinch, three jaw chuck, and lateral or key pinch. The thumb plays a particularly important role. Opposition allows the thumb to contact the fingers and create controlled pinch forces. This is one of the major functional advantages of the human hand. Thumb opposition is not simply one isolated movement. It involves a combination of abduction, flexion, and medial rotation of the thumb at the first carpometacarpal region. The opponent's pollicis is particularly important. The trapezium and the saddle-shaped first carpometacarpal joint allow the thumb to move through a large functional range. The mobility is fundamental for precision grip. Now, an important biomechanics concept for physiotherapy students, the tenodesis effect. When the wrist moves into extension, passive tension in the finger flexor tendons tends to produce finger flexion. When the wrist moves into flexion, passive tension in the extensor tendons tends to produce finger extension. This is also known as active or passive insufficiency. This is an important example of how movement at one joint influences another through muscle tendon relationships. Let's revise the major wrist movements. Flexion approximately 80 degrees, extension approximately 70 degrees, radial deviation approximately 20 degrees, and ulnar deviation approximately 30 to 40 degrees. Exact values vary depending on the reference and measurement method. The important point is that wrist flexion and extension have much larger range than radial deviation. For wrist movements, the end feel is influenced by the capsule ligaments, muscle tendon tension, and soft tissue approximation. The normal end feel is generally described as firm for many wrist movement, although the exact quality can vary according to the direction and testing position. The wrist is rarely used in isolation. During functional hand activities, a slight degree of wrist extension is often advantageous for producing efficient finger friction and grip. This is because of the length tension relationship of the finger flexors. So, a key functional concept is wrist position influences finger force production. This connects directly with the tenodesis effect we discussed. Now, let's move into the clinical anatomy. Carpal tunnel syndrome involves compression or irritation of the median nerve within the carpal tunnel. The condition can therefore affect sensation in the median nerve distribution and motor function of selected thenar muscles. Decurving tenosynovitis involves the first dorsal compartment at the wrist. The two tendons are abductor pollicis longus and extensor pollicis brevis. So the exam association is decurving first dorsal compartment APL plus EPB. Trigger finger involves abnormal movement of flexor tendon through the pulley system of the finger. The A1 pulley is the key anatomical structure. Dupuytren contracture involves abnormal thickening and shortening of the palmar fascia, particularly palmar aponeurosis. This can progressively produce flexion contractures of the finger. The scaphoid is the most commonly fractured carpal bone. Clinically, tenderness in the anatomical snuff box is an important clue. The scaphoid is also important because its blood supply can be vulnerable after fracture. Guyon's canal is located on the ulnar side of the wrist. The ulnar nerve and ulnar artery pass through this region. So compare the two major wrist nerves compression site. Carpal tunnel involves median nerve and Guyon's canal involves ulnar nerve. Let's bring the entire region together. Forearm, Flexor-pronator compartment, Extensor-supinator compartment, median ulnar and radial nerve systems. For the wrist, radiocarpal joint, distal radioulnar joint, carpal bones, carpal tunnel. For hand, Thenar, hypothenar, lumbricals, interosseous, grip, pinch and thumb opposition. And finally, remember the major clinical anatomy association. These are the final rapid fire revision questions. If you can answer these questions confidently, you have covered the major regional anatomy of the forearm, wrist, and hand. This completes our revision series of the upper limb. Please like, share, and subscribe for more such videos.